Okay, sorry for my delay to attend this meeting. Thank you for giving me the opportunity to give the small lecture and a small talk with all of you. My honor to be here, Professor Choi, John, O, and all my friends in Asan, and I saw a lot of international colleagues. Thank you for coming today. This is my little topic this time when I will be in Korea. So the first one is what I have done for my research according to the head chef. Okay. This is all my faculty in Taiwan, and this is the Chang Gung Memorial Hospital. However, I checked all the photos around about the house, and this is a very cute cartoon tool, the pictures. Yeah. So I got lost, this morning. I don't know which building is 5 or 10. So yeah.
This looks like a Ghibli style.
Ghibli now it's very hard. Thank you, Dr. O, for the last night. Yeah. So I really got confused. I have to. Yeah, that's why we have a lot of wake up drink after the album. I have a very nice relationship in between Chang Gung and Asan's several years ago. Like we invite and we meet and we have nice conferences. We have very good talk with Professor Choi, Professor O, or even like we were in ECPCA in Milan. Dr. O is the representative of the Korean be there, and Professor Choi came back. And the first time when I met Professor Choi was in 2019 when we were in Paris, in France for the ISCFS. Yeah, at that time I seriously know Professor Choi is so powerful and very good and knowledgeable and dominant in all the Asian society of the craniofacial surgery. Okay, and I got one book and I have his very authentic signatures on this book. Thank you very much, Professor Choi. I have to remind myself back to 2016 when I was in Dallas. This was my 1-year fellowship in UC Southwestern. And I was being recommended by my mentor, Professor Lunzo Lo, and my very, very mentor, Professor Fuchun Wei. And when I was there, because I am a member of the Craniofacial member in our team, so in the very beginning they want me to do some image-related topics. So this is my first time to know how we can use the three-dimensional image to evaluate the patient of the cleft to receive the first surgery, that is the lip repair, and how the NAM devices can work before the lip procedure, how they could reduce the lip width and how they could reduce the arch width. So weekly we invite all those patients come back to receive the three-dimensional image that we record and we use in the three-dimensional image analysis to know that NAM's work is so powerful and effective. So that's why nowadays the NAM probably is kind of very necessary tool before the lip repair to be used. And then I try to evaluate all the head shape, and in states that might be the synostosis cases, it can get a very nice insurance coverage compared to those the patient in our country. So I evaluated how those patients who receive synostosis repairing and the head will progress it in the future, and I use the three-dimensional way as well to evaluate which part they progressed. And then we can easily to know the hum map and the heat map to know which part of after probably the sagittal or the metopix or the coronal, the synostosis, after the cranial repair, how the cranial will be enlarged at what apartment, and it could be easier for us to inform those parents how their head shape will be formed to later. And this is my mentor in UC Southwestern, Alice. Alice is one of the Jeffrey Marsh's fellow as well. And he has the same time as the fellowship with my mentor, Renzo Lois. I got a good connection with the Alex. And in Texas, a lot of patients coming from Mexico. So we have lots of cleft patient, congenital craniofacial anomaly ones. So we try to use in the three-dimensional model. UCLP, PCLP, even only the product defect, we can easily inform the parents what is the real defect inside the intraorally. So it's a very nice, good educational model. And when I was there, Richard Harper is one of our visiting professors. So Alex introduced what he had been done in Dallas, because he invited the surrounding of the school, the student, coming to the Southwest to the imaging lab. This is one of the three-dimensional, the machine is so-called the 3DND. So 3DND so far now is a very good facility, because it not only can take the three-dimensional image, even furthermore, it could include the time. This so-called four-dimensional way, it can include a little bit short term, and you can evaluate, for example, for a facial paralysis patient, when the patient received reconstructive, maybe before the surgery, he cannot smile. After surgery, maybe do some maybe facelift or maybe the reanimation surgery, patient commissioner can lift or elevate it. You can easy to record the change, the kind of morphology change by this the four-dimensional way, so you can know how your surgery works. Yeah. And when I get back to Taiwan in 2018, this is my new member of faculty, Professor Ray Chen, Professor Yolo, and it's me here, very honored. And at that time, Junior still
I was still
still a baby. So my very beginnings, the research is to know what is the control. It's so-called what is the normal, the head shape in general. So why I want to know this issue is because we have a lot of craniofacial normally babies since the neonate, and we have a lot of patients in our data bank, but we seriously not really know what is the normal or healthy baby they look like. It's very important as a control group to be very nice, differentiated, and we can know what is our target to go for treat every single patient with the cleft or any other abnormality ones. So in our institute, we have one similar nice 3D machine as well. So we invited all those school students that just situated around our hospital, Chang Gung Memorial Hospital. We invite them to come to our branches, and they sit inside and take the three-dimensional photo. Just only take you maybe less than 1 minute, one second, just like this. Okay, sorry. Very much. Okay. So you can easily get a one three-dimensional reconstructive photo like this. So you can see this lady, these little girls, very clear and very detailed the images, and you can see every recognizable anatomical landmark in his face. This is my second son. Thank you. Yeah. So we collect a lot of such kind of a big group. This is my big son. So because I need a lot of data bank, so I have a lot of children. So this is all the school they situated. It's just around kind of neighborhood of the Lincoln Chang Gung Memorial Hospital. Okay, and what we can deliver the service that is we rent a lot of buses, and the buses go inside the school campus, and then we can take a bus, and the bus come to our hospital to receive the 3D the image. However, they are very bored when they are waiting in the line to receive the 3D image. So we specially to arrange two different programs for them. The first one is they can receive the orthodontic examination by our pediatric orthodontist one. Why we want to know? That's because we want to know when the kids are growing, what the orthodontic change. Right? We know the morphology of the maxilla and the mandible, they progress and develop is the different peak of when they are in the development progress. So we want to know when the patient is around the age of 9 to 10 to 11 or 12, what is a crucial change. So we do evaluation 1, 2, 3. In the second program, we invite a pediatric psychiatrist, is kind of mentors or the physical therapist. And they can come join with some game, and they can like actor, player together, and we can consume some of the time they are waiting for the image to take. And I myself can teach you how to teeth brushing as well. Okay, so it's a very good time for me, and to can get much closer with those subject, and can deliver the 3D image as well. So this is one of our protocol to invite all the norms, the healthy, the school students come to our hospital, and then we publish as one of our algorithms how to recruit such kind of healthy children to come to hospital to receive any kind of image studies. And we collaborate with the Copenhagen and the Dallas lab teams to using the main lab base evaluation the image the tool. And we include a simplest by algorithm and a closed point deformation. These two, the coding is easier for us to evaluate any kind of three-dimensional image waves. So in our first paper to know, in all the general Taiwanese the school students, we can find the red one is protrude much larger. The green one is a little bit retruded. So in our populations, the kids in this elementary school stages ones, you can easily to find the right side is much progress. So maybe although you can touch your head, right? And the left you can feel is any tendency like this, right a little bit protrude in the left side. And even in the face, you can easily to know the right face is much little bit larger than the left one. So it's very very curious the finding about this, and we go to check the literature before any such kind of study like us. Yeah, such paper already be published already. And however, we use the more advanced and the more technical way to prove it. And even in the face, you can still find some facial asymmetry from the kids as well. So you can say once the skull base progress develop in some asymmetry tendency, the face will follow the tendency as well. So you can feel your face is any different side of face you have been. Yeah, this is one of our another paper. And we can easily to make some asymmetry ratio or the scale to determine those kids level on the severity of the level 1 to level 4. Level 1 means is less asymmetry. Level 4 means much asymmetry. And we make a questionnaire to invite the 3 different panels. The first one is our group, plastic surgeons. The second group is their parents or their maybe in the age around 20 or 30. And the third group is their classmates, all those school students' classmates. We show them the photos and I ask them, do you believe this subject is asymmetry or not? And we are looking for the 3-dimensional image. And it's a very interesting finding. Even in this level 1, it seems the less asymmetry one. Those, the pre-adolescent observer can be more sensitive to identify the differences, the very, very tiny asymmetry inside the photos. That means even those the kids in the school stage, they can easily to recognize the differences between you and me, and even in the face, they can look easily to know that they are asymmetry. So it possibly maybe it's a kind of a sense for you to know the body sensing is maybe in a very young stage they can recognize those differences and can get more motivated and to feedback in different way. So what I launched such kind of project is want to inform those teachers in school. We have to pay attention to those sensitivity of the children. Might be the body, the status can be reduced. All right, and in the level 4 is a more advanced asymmetry. And in the laypersons, maybe they only can read a little bit less. However, those the pre-adolescent observer is really has the same level as a plastic surgeon to look at what is the real asymmetry one. So what I want to emphasize is that in our school, students already got a very high sense of looking at what is the real asymmetry. So some paper published, we can recall because these 3 are all my children. Yeah, so they're all already in all the journals. And then we go back to the school campus to address what we found because they are all a very nice contributor in my project, in my study, and I go back and this is a poster. So in the past, maybe 8 years, was a lot of cases we already invited back year by year for this three-dimensional image way. So you can see, yeah, this is another subject, 1 year by 1 year. But you can see we have known 2022. That's because COVID. Okay, COVID hospital is a very dangerous zone. Okay, so those are healthy, even unhealthy patients don't want to come back to the hospital, even though those are healthy ones. Okay, so never mind. And we go back to see what is the occlusion-based, the differences in between the three-dimensional way. We use the MATLAB as well to look into class 2 and class 3 school students. What is the differences of the facial symmetry? And as we know, in a very common sense, class 2, we have more convex face. And class 3, like me, we have more convex face. So we can easily to know in class 2, the facial symmetry will be highlighted in the mid face. And especially for the class 3 one, we have more symmetry over the low face. And more interesting, the project is we want to know those school students. Does the hand predominance have a predominant influence on the craniofacial symmetry? For example, I am the right-handed. Maybe we have some guys as the left-handed in this room. Any the right-handed or left-handed, we have some correlated to your facial symmetry. Thank God, there is no association in between the facial morphology and the hand predominance. That means right and left-handed, there is no any relationship in between the craniofacial symmetry. Okay, yeah, interesting. And then I look into the neonate. We are not only to focus on the school met because they are already grows a lot. The change is very tiny. We want to look at, my first paper in UT Southwest, we want to know the healthy one, the neonate, the normal one, when they grows. So I go to the baby room in Chang Gung and I announce and persuade all those new parents, can you give me your baby? We can give a kind of 1 year. It's not a long-term follow-up, but I can do something within the first year of age. I invite them come back to my 3D image lab in their 1 month of age, 2 months, 4 months, 6 months, 9 months, and 12 months. And you can see something differences in their head and face. So it's another kind of a neonatal craniofacial morphology three-dimensional image study. So we can do some evaluation from the 1 month, 2 months, and then we differentiate into the male baby and the female baby. Okay, like this. And then we can have some plot, including we can know what the body weight, body height, body circumference is, and the head shape, AD view, dimensional, anyway. So this probably can be the future of in Taiwan is normal, the progress, the curve is very similar like this, like this. Because now in the pediatric neonatologist, the doctor will evaluate and measure what is the head shape and the body weight, and to give you a range. Maybe you are overgrowth or you are less growth. You can easily to know your baby is inside the normal range or not. And then my way is want to use a very simple, like the phone. You can easily have you can scan the baby's head shape, and you can measure the progress in the stage according to his head volumes. Okay, it's easy to be evaluated like this way. Okay. So we published one related paper in talking about the craniofacial growth and the asymmetry in the newborn. So it's kind of longitudinal three-dimensional assessment. And this one already be a lot of relative the center invite us to share our data image with them. They want to expand, and we can collaborate in between. And finally, such kind of project Sevali, and according to the project Sevali, I know in Korea, such a lot of paper, they are coming from very nice article from Korean society, and then we try a little bit modify what we can define as symmetry, and then we give some algorithm and principle, and this is for a new paper like this. And finally, I have to introduce one of our craniofacial Chang Gung webinar. I have to say thank you, Professor J.W. Chou and Professor O has been in this webinar platform to deliver a very valuable and a very nice presentation for all over the audience in this world. Already have been held 101 times, so it's a very important milestone anyway. So Professor Choi, Professor O, and we have some Korean friend, Jun-Yu and PK. So yesterday, I take one bowl and a plate. I take another pen inside my backpack for Professor Choi later. Okay, we can take a photo like this. Yeah, from Taiwan to Korea. Thank you so much for all my fellows in this, all my previous studies. This is my info. So yeah, these three guys, thank you very much. So yeah, these three guys, thank you very much.
Any comments?
It's excellent works. I'm really impressed. So really appreciate you try to establish the Asian standards, so which is not common until now. So actually, for a long time, I have considered to establish the Asian standard in regards to the cephalic index. So cephalic, mesocephalic is known to be a cephalic index between the 75 and 80, but that is the Western standard.
Yes.
So did you study about the cephalic index as well?
Yeah. Cephalic index is now is a very simple one, and for our clinical physician, easy to randomize how severity of the craniofacial asymmetry by the cranial index. The cross line 30 degree, and we can take these two different arm of the lens and the minus and for the ratio part. However, that's why we want to develop our own, like this one. It's more complicated one. Yeah, we divide into the different angles and in different labels. Yeah. However, it's not easy to be applied in the routinely clinical be used because it's too complicated one. But it could really to highlight more in detail where is the side of the symmetry one. So for our practice daily one, I think the craniofacial index is more easy to be used. However, this one is maybe we need some cell phone or smartphone and with the software inside, and then we can scan and take another index. Yeah. So we are going to compare these two different evaluation tools. But CI is always our common tool.
Yeah.
Yes.
I have a quick question for the 3D MD system.
Yes.
I think that the software also has some analysis function, and when we measure the symmetry, and how does the system set the midline of the face?
Yeah, this is a very good question because every time we want to see the asymmetry, we have to know where is the baseline or where is our mirror, the plane. In our previous study, like the evaluation tool, we take all the subject and just what I say. Okay, where is it? Okay, this is what the tools we evaluate. We not really need to identify what is our mirror plane and what is our core, but we have to put lots of probably 32 the recognizable anatomical landmark in all the three-dimensional face, including the subnasale, the ear, the eye medial, and the lateral pincers, and anywhere, and all the face. And then we have the radiations landmark as well, seen from the upper face, upper head, there's some radiation dot inside the scalp. We not really can find a real point of plane to do the asymmetric analysis. However, we're using the coding. Those dots can be printed in the two-dimensional planes. And then we have put any the axis like XYZ, the axis one. And they can later, we can calculate the average one, and they can re-establish a real three-dimensional head shape. Is kind of our template. So we're using a template to identify each differences in between the subject and the template to know the symmetry, how severity that is. Okay, so it's by the coding program, not really to see which is our symmetric plane or which is our core point.
So last year, when I visited the Chang Gung, you have very good facility of the research building that regarding the AI, do you do or do you prepare any AI-based research? So
Yes.
if it is not available, you don't need to say.
We want to develop a new AI assistance, but we need a more big volume of the subject data bank. Yeah, because the AI need more the materials and the subject inside the data bank. Yeah, we are still trying and error, because somehow 3D the machine, they have its own spontaneously marking the facility. However, it's still a little bit deviated to the real position and the point. We need our own to move the point to the correct point. Otherwise, sometimes the AI will direct you to very, very tiny differences. Yes, still.
Thank you for a great talk. Very interesting, and I think you have a really very interesting curiosity for measuring everything. And do you have any data that whether that's measuring with the three-dimensional structure is correlated with the CT angio image? Can you tell that is the bony deformity, or maybe if the patient had a hair, maybe that parting of the hair might be if affect the 2 millimeter difference of the measurement? And can you tell that's really meaningful in our practice, whether to see those kind of minimal changes?
Yeah, this is very, very, very important questions. Yeah, for the first one, should we need to compare with this the three-dimensional texture photo with the CT image? However, unfortunately, we cannot get those the CT image from the healthy babies or in the healthy school children, because they are not have any maybe the purpose to receive those kind, and IRB cannot be approved. So we only have a three-dimensional texture photo can look involved in our 3D-dimensional data bank to include analysis. So for those the healthy subject, we cannot have a CT image. The second one is the very important key point is that the hair. So that's why we have to wear this nylon cap. The nylon cap is very important to reduce the hair impact for us to evaluate each subject image. However, for male it's easy to very, very contact the hair to the scalp to reduce the bias. However, for some girls, even the girls has a ponytail, it's very difficult. We have to seriously, they are not a very good sample in our study group, because the ponytail we give a very influential factors, because they will impact or they can maybe enlarge the posterior occipital area for our evaluation. So my data in school students might be not so accurate. Like this, in our first year, still have some hair outside of the cap. And then finally, the ponytail, definitely. Recently, we can much easier to have the nylon cap much touched, yeah, in this scalp. But for the, for the neonate, I believe they are not have very enough hair. So in the neonate study, they can more purify the data and to already have very nice head shape correlate to their real head type.
Yeah, so I saw the data from the first months to the 12 months you showed. So
Yes.
there's no difference, and also the contralateral side was more bulging. Maybe
Yeah.
that might be the reason for the hair.
Yeah, might be. but the hair is really very soft compared to adult hair.
Okay, we have
Yes.
next speaker.
Pleasure to be able to come to Asan, and it's good to be back after 2 years, and good to see all our good friends here. So there are two types, basically congenital and traumatic, and there are many variations. But first of all, we have to distinguish whether the congenital auricular deformity has a cartilage deficiency or not. So, for example, these parts where there are no cartilage deficiency, then our first line of treatment is actually with splinting. Now, you probably hear some commercial products such as like Earwell and stuff like that where you can correct it, but at our institute, what we do is we actually produce our own splints. Now, we make these splints out of 3D printers, and then we print like a whole series of them. So the size that you see here, actually it comes in like 7 sizes. So we specify them from like left side and right side, and then size 0 to size 7. Now what I do is when patients come in, I would let them, I'll fit it onto them and see what size that they wear. And then sometimes you might need some adjustments on the fly, and then you can do that with some burrs or something. That's really easy to do. Now this works because when the baby is just born, the ear is really soft due to the cartilage having a maternal estrogen effect. However, as the baby becomes a little bit bigger, the maternal estrogen level decreases, and then it doesn't work as well. So this is why we always say that the patient's the golden treatment period of time is probably before 3 months of age. Now, is that an exact number? I feel like it's not. I've treated patients who are even older than 6 months old, and it still works, but it differs. But the best timing would be when they're like immediately right after they're born. Now, usually I ask them to wear it like 24/7, take it off only when they're showering, but it really depends. Some patients, parents don't comply as much, and then the duration of treatment takes a lot longer. So I just want to walk you through some of the things that we are dealing with. First of all, cryptotia. Now, you've probably seen this type of condition when the top of the ear is buried underneath the skin. Now, if you pull the ear outwards, you'll see that the cartilage is actually intact. Now, what we need to do is, at first, we need to use a tape to tape the upper sulcus. So what I do is I use a backward V, actually a downward V, and tape the side, one on the front, one on the back, and then I ask the patient to wear a splint on it, and then fix it in place. Now you can see that after a couple of months, the ear shape is very smooth. Now the next condition is lop ear. Lop ear is when the top of the ear tips downwards. So you'll see like it'll fall downward like that, but there's no cartilage deficiency. So again, what we do here for these patients, we ask them to wear a splint. At first you don't see the superior crust, but after you wear it, the superior crust is very visible. And for this patient, it only took this patient like less than a month to get that shape. But when the patient comes in, like when they're old, this is a patient 30 years of age. Now this was the original condition that he had. At this age, you can't correct it with splinting. So what we need to do is we need to rearrange the cartilage by surgery. So I did a retro auricular incision, and then I rearranged the cartilage. If the rearrangement doesn't work, what you'll need to do is you'll need to harvest a costal cartilage graft for support. Now, I feel like that's a secondary effect. If you can get this effect from just rearrangement, that's what I'll do. So when patients come in, I'll always explain to them, I will try to rearrange the cartilage. If not, I'll harvest the costal cartilage graft on the spot. So in that simple surgery, if I can't rearrange it, I'll harvest the costal cartilage and I'll perform the support. Now, this next condition is constricted ear. Constricted ear is when the helical rim is really, really tight. You'll see this in a lot of patients. Now, some patients feel like this is not a deformity, but recently I feel like a lot of the parents are a little bit more anxious to have this fixed. So they're coming in a little bit more for this type of condition. Now again, with splinting method, you can get a really good contour. Next is prominent ear. Now prominent ear is very funny because this is a different treatment from the previous conditions. Now what you'll see is with prominent ear, you'll probably usually see that it's a little bit more projected, right? And then another special feature is that usually the anti-helix is not as prominent. So that's the normal characteristic of a prominent ear. Now what I usually do for this type, I don't ask them to wear a splint. What I do is I use tape. I just tape it downward and then put a fixation. Now I feel like the importance is the backward fixation on the back ear, because the ear has its cartilage support that it will want to return to its original state. So what you'll need to do is add that little piece of tape on the back end there and just put it downwards. Now, one thing that you'll need to keep in mind of is that baby will still have hair. So when there are hair on it, the tape won't fix. So you'll have to ask them to take off a little bit of the hair in the back to shave it off so you can really tape it downward. And that's how it works. And then you can see that after the taping is done, you'll have the really good anti-helix. So what you'll need to tell the parents is that the amount of tape, like after you tape it, the contour should be what you want it to be. Same thing with splinting. When the patient wears the splint, it should look like how you want it to look like. So afterwards, when you take it off, it'll look like this. Now, if that doesn't work, or if the patient is a little bit older and you can't do this taping method, then you'll need a surgical intervention. Now, for some patients, of course, if they don't have the anti-helix, after you do the correction, you can see the anti-helix. But of course, you have to also look at the angle of the projection. Now, for some patients, if they already have the anti-helix, then you look strictly at the projection. I usually perform this type of surgery under local anesthesia because I feel it's very important to have the patient to weigh in on how much they want their ear to be projected. Now this patient, I think, was a patient around 40 years old. They are very, very self-conscious about how they want their ears to look like. So you have to ask them, is this enough? Because for this patient, I probably did 2 or 3 adjustments on the same procedures, because every time I set the ear back a little bit, the patient felt like it wasn't enough. Okay, and then a stall ear. Stall ear is actually have the characteristic of a third crust where it protrudes to the sides here. Some people call it the horizontal crust. And then you can also do a splinting method where you can try to push the horizontal crust downwards so it doesn't look as prominent. But if the patient is a little bit older, what you can do is you can actually do a wedge resection. But you'll have to make sure that you kind of align the cartilage together so that the cartilage is smooth, have a smooth contour. Okay, now my actually specialty is microtia. In our institute, we actually have 2 types of microtia reconstructions. The first type is autologous coastal cartilage, and then our second type is alloplastic porous polyethylene. Now we do a little bit of a combination, which means that for some patients, if they had a reconstruction done with coastal cartilage, if I need to do a second stage of projection, sometimes I would choose to use the porous polyethylene for that second stage, so I don't have to harvest the cartilage again. Now, I know recently there has been the use of irradiated cadaveric coastal cartilage, but we haven't done that yet at our institute because it's a lot more pricey, so that's why we don't do it. Now, autologous coastal cartilage, we still perform a 2-stage surgery where the first stage is we harvest the cartilage, we shape it into the shape of the ear, and then we bury it underneath the skin. And then around half a year later, we ask the patient to come back, and then we do the projection surgery. Now, this surgery is only suitable for patients 9 years old or older because we need to make sure that their coastal cartilage has been fully mature, so that after we harvest the cartilage, there is no defect, but there is no deformity of the chest wall. Now, as for porous polyethylene, it's a single-stage surgery. We actually perform this surgery for patients who are 5 years or older. And then people usually ask me, well, isn't 5 years a little bit too young? Well, actually, no, because at this age, I think patients' ear is around 90% of the adult ear size. So when you correct it, the asymmetry, is insignificant when the patient grows up. Now, I'll talk a little bit about the simulation tomorrow at the talk, so I'll skip this part. And this is just one of the cases where, 6 years old, after we do the surgery, this is the regular side. This is after the surgery. And then you can see that you can actually have a really, really good depth of that conchoid cavity. And this was done with the porous polyethylene. And then post-months, after 2 months, it's a really good looking ear. And then after 10 months, the ear shape is really good. And then the skin texture is really good. And we harvest the skin graft from retroauricular and arm, and then you can hardly see any scars. Yeah. So I'll just walk you guys quickly through some traumatic conditions. We also deal with split earlobes. I think everyone sees a lot of that due to the earrings. And then also there are cauliflower ears from trauma. Now, usually you want to drain that hematoma in the initial changes, but if you don't do it in the initial stage, the cartilage becomes really, really firm. So what you'll need to do for this type of condition is that you'll have to open up the skin. Usually I do a helical rim incision, and then what I do is I use a burr to burr the cartilage because it's really hard. I try to do it with knives to carve it or with some carving stuff, but it doesn't work because it's way too hard. So what you'll need to do is you'll need to use a burr to burr it. Now, our next condition is auricular perichondritis. Now, what I want to say about this type of condition is that usually IND is the best way to approach this type of patients. But if the patient doesn't want it, what you'll need to do is treat the patient with antibiotics, right? So actually, the most common pathogen is Pseudomonas aeruginosa. So what my hospital doesn't let us use ciprofloxacin because they feel like it's a ladder treatment. So what I do is I use the first line antibiotic, but I only treat it for 1 week. If it doesn't work, then I'll immediately shift to ciprofloxacin because this type of antibiotic is perfect for treating Pseudomonas. So keep that in mind. And then after treatment with the ciprofloxacin, you can see that the inflammation decreases right away. Now also you see some patients with earrings comes in with ear cartilage wrinkling. What you want to do is, again, you want to rearrange the cartilage. What you can do is, this is just from rearrangement of the cartilage. You can get a nice contour. But however, since there's some irregularity of the helical rim, I asked the patient to come back for a third operation. And then what I did was I stuffed some dermal fat over there and smoothened out the contour so it looks good. So yeah. And then for ear keloids, I just want to say that usually the previous golden treatment for ear keloid was the surgery, steroid injection, and then steroid taping, right? But nowadays, our treatment has changed a little bit. What we do nowadays is now we do radiation therapy for patients who have repeat keloid growth. So what we do is after we treat it with surgery, within 24 hours, we'll ask them to receive radiotherapy from our radiotherapist. And then what they do is a single fraction of 8 gray, and then 1 time treatment for the radiation. And then after that, we'll ask them to continue taping with silicone tape. So for some patients, if it's at the retroauricular part, I feel like you don't have to worry about the skin, because sometimes you worry about the skin, right? You have to do the skin grafting. But if it's retroauricular, actually the mastoid flap is really, really flexible. So I think anything, if you're dealing with a retroauricular keloid that is under probably like 50% of the size, then what you can do is you can advance that mastoid flap forward and then just use the mastoid flap for coverage. And as you can see here, with the mastoid flap, it looks really, really nice. And so my conclusion is that there are various type of auricular conditions, whether it be congenital or traumatic. But if there is no cartilage deficiency, then for the congenital parts, I would recommend splinting for treatment. And for the rest of them, you'll need surgical treatments. So yeah, that's my talk. Thank you, everyone.
Thank you for a great presentation. I also do your construction in our hospital, so I have many curious questions to you.
Yes, please.
First, my question is, how do you think about optimal operation for minor ear deformity, timing of age?
Actually, for the minor deformities, I still ask them to come in at around 5 or 6. I feel like that's a better age, only because I feel like with ear surgeries, you'll need like post-op care, right? But patients who are under 5 are really, really hard to take care of. They won't stay like, they won't let you change their wounds and stuff in OPD. And then, so I feel like 5 or 6 is better. Now, even for, I don't know if you've seen like the cleft ears where there's some small minor clefts. Now, for those patients, some parents will want it to be treated immediately, or if we're talking about like preauricular skin tags, but I still ask them to come back a little bit later, because when they're small, you still worry about the anesthesia, even though I don't feel like it's a big problem that you have, but you know, if you can delay it, the more the better. So I still ask them to come in at 5 or 6. Usually now that's the youngest age where I'll perform the auricular operation for them.
So your procedures are the local anesthesia?
No. For my preference is for patients who are under 10, I'll always perform general anesthesia. But if they're above 10, then I would consider, depending on how they act, how we interact in OPD situations. Yes.
And based on your the photography, I think you use endoscopic temporal fascia.
No, actually, I just do it. I don't do it with endoscopic. We tried, but it becomes so foggy that you have to take it out and then wait every like a couple of minutes or something. So it's too time consuming. So what I do nowadays is I just do an incision along the hairline, and then I harvest my temporal parietal fascia that way. It's quite time consuming, but it's only consuming for adult patients. For young patients who are probably like under 15 years old, the temporal parietal fascia and the skin is usually, the separation is usually quite easy. So I can probably finish that within 2 hours. Yes.
Great. And I met Rennie from the UCLA in the conference of ISA.
Yes.
I heard that he used the temporal skin, the main skin for the anterior part of medical implant,
Yes.
comparing the physically skin graft. So how do you think about that?
I totally agree, because nowadays what I do is I use the contralateral retroauricular skin for the anterior, so that when patients look at you, the skin is quite symmetrical. The skin color is quite symmetrical. Now, since you're harvesting the retroauricular skin graft, so what you'll end up with is bilateral skin defects, and I harvest the arm or inguinal for that, for the retroauricular part, because the retroauricular part, people won't be able to see the skin. so that way the skin color doesn't matter as much. But usually that the patients decide whether they want to harvest the arm or the inguinal, and because I feel like it has its pros and cons. Now I know our old method was we harvest scalp, split thickness skin graft, but what we're seeing is that sometimes the skin color still doesn't match, and also since it's a split thickness, so sometimes the contracture is a little bit more, and with skin contractures, sometimes it makes the scars a little bit more visible, and then sometimes it pulls the ear a little bit backwards due to contracture. So that's why I don't usually recommend using the split thickness skin graft anymore unless it's like a bilateral microtia case. Then I would consider it for the anterior side.
Thank you. My last question is, you use a method for plug and carving everything?
Yes.
Wow.
Yes. So what we actually do nowadays, we use the same 3D MD machine. We simulate the ear shape, and then we print it out with 3D printer, and then we carve the mat port according to the 3D printer.
It's very time-consuming process.
Yes. Yes.
Why don't you use the already made
Actually, nowadays, Supor has the
right.
already made implant, right? But I think there are two problems. One is that because people were shifting from cartilage to porous polyethylene, so people are used to a customized ear, so they want the ears to look symmetrical. Now, the second problem is that I looked at the Supor implants. I feel like they're a little bit thicker than how we like ours to be. So yeah, that's why we don't use those. But I feel like it's a good alternative, especially if your hospital doesn't have a 3D MD machine, or if the patient doesn't really mind about that, they don't need their ear to look exactly the same. I think it's a good alternative to use anyways.
Thank you.
Yeah.
And I very inspired by the splitting because I am doing also the plastic surgery. So before surgery, the pre-nam, but I think that I should change something after seeing your speech.
Well, I think with Asan, you guys have like such a good team.
Yeah,
So I
but-
think
But we needed to modify something. So
교수님,
and
저 제가 하고 있는데 모델 제가 하고 있는데 똑같은 거서 하는데
and so and for the timing of a total ear reconstruction after
Yes.
using the porous polyethylene, so when do you do the surgery total ear reconstruction? Because in Korea it is too late when you use autologous cartilage.
Yes.
Yeah.
Usually,
Over
I
10.
think nowadays my patients are usually around 6 years of age.
6.
Yes, 6 years old.
But the size, how about the overcome the size after growing?
So that's a really good question. Now I've been doing some studies that I'll probably publish in the future about determining the ear size. But I think right now our mentality is that we try to make the ear size slightly bigger when they come in at 6 years old. Now, when they come in at 9 years old, I usually don't change the ear size because I feel like that's the adult size. But that's my current method right now.
And how do you manage the exposure of the
Yeah, so
implant?
exposure of the porous polyethylene is probably the most complicated thing to do. But usually what we do is, since we are harvesting the superficial temporal fascia, right? That's our initial surgery. We still have a deep fascia underneath that we can use for salvage situations. Now, if that still fails, there is still the temporalis. Now, all I can say is that, you know, with each surgery, the result will look worse and worse for the outcome. So, yeah, I think if you have to salvage with the deep fascia, usually the result can still be quite satisfactory, but after that, it gets worse. And then if there's nothing left, then you are actually facing with, you know, using a free fascia, maybe from like the contralateral side.
I
Yes.
have a very simple question. I'm not. My name is John, and I'm not doing a ear surgery, but I saw the in a prominent ear you did a taping and creating a circus more prominent. So
Yes.
if the patient doesn't have any circles in the ear with a prominent ear,
Yes.
and then is it possible to make a circus just with the taping?
Well, it only works if it's a baby. So I think if it's like a patient is like under 6 months of age, we can do that. But if it's an adult, I think it's impossible. Then we'll need to do surgery for it.
Oh, okay.
Yes.
Okay. Thank you.
Thank you.